Good afternoon, dear colleagues. Thank you for the opportunity to present my investigation. Let me introduce myself and my research topic. My name is Boglárka, and I am doing my research work at the Semmelweis University Heart and Vascular Center. We would like to investigate heart failure patients. My vision is to help heart failure patients receive the most effective evidence-based therapy, and my mission is to conclude from observations which we can include in the everyday clinical practice. We want to do two analyses based on heart failure. The first is a meta-analysis, and the second is also a meta-analysis. Let me see the first study. The benefits of adding a defibrillator to cardiac resynchronization therapy. We wrote the article, but currently we are waiting some additional analysis from the statistician. So if we get it, we would send it to internal review. Some thoughts about the background. Cardiac resynchronization therapy with or without a defibrillator is an effective therapy in selected patients with heart failure and severely reduced left ventricular function, as demonstrated in several randomized clinical trials. CRT has two types. CRT-D is with a defibrillator function. It can, we used it patient with high risk for malignant arrhythmias. And there is another type, CRT-P, it is without a defibrillator function. It can only pace and resynchronize the chambers. While CRT-D may further improve survival over CRT-P by reducing sudden cardiac deaths, but it also adds defibrillator-specific risk, such as lead failure and inappropriate shocks and its cost. However, the benefit of CRT-D over CRT-P is still unclear because no head-to-head randomized controlled trials have been designed to compare these two treatments. Our aim was to evaluate the long-term benefit of adding a defibrillator to CRT and to compare CRT-D to CRT-P regarding all-cause mortality and cardiovascular mortality. Here you can see our clinical question and our PICO, so we would like to compare CRT-D and CRT-P in heart failure patients. We hypothesized that CRT-D is superior to CRT-P. We conducted a systematic search, and we had 29 full texts. Here you can see our results. We would like to see the all-cause mortality based on adjusted hazard ratios. We can see that the hazard ratio is 0.82. It means CRT-D can reduce the mortality by 18%. We would like to see also the all-cause mortality based on propensity score matching because it is the most valuable way to measure observational trials, and we can see that CRT-D is superior to CRT-P. If we see the CV mortality, heart failure mortality, and sudden cardiac death, we see also that CRT-D is superior to CRT-P significantly. Regarding non-cardiac deaths, CRT-D also superior. The hazard ratio is 0.58. We perform subgroup analysis also because it is really important regarding cardiac resynchronization therapy. If we see ischemic heart failure and non-ischemic heart failure, we can see that the hazard ratio regarding ischemic heart failure is 0.79, and it is significant. But regarding non-ischemic cardiomyopathy, there was no difference between CRT-P and CRT-D therapy. Patient above 75 years, we can't find any difference between the two therapies. The hazard ratio is 1.002. we wanted to see the articles based on the enrollment dates. So we performed a method regression. We get the medians of follow-up periods, and we saw all the articles in one plot. But we can't find any time dependency between the articles and the hazard ratios. Our study has some strengths and limitations. The strengths, we could analyze 8 articles regarding propensity score matching, which is a really prestigious data. We have several additional outcomes not presented in any other meta-analysis before. We perform subgroup analysis based on etiology and age, and our analysis is the first in the literature to evaluate time dependency based on hazard ratios compared CRTD and CRTP directly. But these are only observational studies, and we have only 3 articles regarding the additional outcomes, and the GRASS article has a huge impact on the results. So our conclusion based on our results, CRTD is superior to CRTP regarding all-cause mortality, sudden cardiac death, cardiovascular mortality, and non-cardiac death. CRTD is beneficial for ischemic patient, however, patient above 75 years, and non-ischemic patient could not benefit from CRTD compared to CRTP. And we found no time dependency of hazard ratios. So we should implant CRTD devices compared to CRTP, especially for ischemic patients or patients who have high risk for sudden cardiac death, and patients above 75 years cannot benefit from additional ICD. And it is very essential to define subgroups more precisely who can benefit from CRTD implantation. Our second topic is about heart failure remote monitoring. The title is Continuous Invasive Remote Monitoring in Patients with Heart Failure compared to regular in-clinic follow-up. Some sentences about the background. Annual hospitalization related to heart failure in the USA and Europe are estimated to be over 1 million. Remote monitoring in heart failure patients is an approach used by clinicians to enable earlier intervention in cases of disease progression. However, the guideline is recommending remote monitoring at a high level, but there is no exact evidence for using it. In Hungary, 20,000 patients live with CIAD, and only 1,500 patients were monitored with a home monitoring system according to biotronic data. So remote monitoring is underused yet in Hungary, but in this pandemic period, after the pandemic period also would significantly reduce the burden on hospitals. So our aim was to assess whether the use of continuous remote monitoring in heart failure patients leads to reduction in all-cause mortality, heart failure hospitalization, and cardiovascular-related hospitalization compared to standard regular in-clinic follow-up. Here you can see our PICO and clinical question. And our search, we have 15 full texts, but we are waiting for all the data from the statistician. Thank you for your attention.
Thank you for the nice presentation. I would like to ask you if you plan a subgroup analysis also by the method regression or not.
Thank you for the question. Yes, we would like to perform subgroup analysis also based on the etiology, and our statisticians, I think he is working on the topic right now. I hope we will get the results until 1 week or 2. Thank you.
If there are no other questions from the audience, I would have a question to you. What is your explanation on non-cardiac death? So CRTD is good for everything, it seems.
I think we have to know that in these articles, the populations are very different, so these are very heterogeneous. So CRTD patients are younger, and CRTP patients are older and have a higher rate of comorbidities, so maybe this reason, not because of the CRTD therapy, it's the patient characteristics.
I got one more question. Just one, a short one. Are you aware of the financial bias of selecting the patients for CRTP or CRTD? Because the CRTD is much more expensive than the CRTP.
In these articles?
Yep.
I think, yeah, there was some financial bias also and financial decision in these articles also. So maybe this reason.
It would worth a look on that, because there are some not very rich countries who implant also CRTs, but they insist on implanting the cheaper one for all those patients they have. Again, they should get CRTD, so it may happen that there is some kind of regional influence as well on that.
Yes.